Hello and welcome to the multi-level health information modeling tutorial series.
In this section, we are going to address the ontological complexity of healthcare information. It's important to understand that healthcare is the most complex area of human society in terms of ontology. And I'm sure that one of the best examples about it is the size of the greatest medical terminology, SNOMED-CT. SNOMED-CT has more than 310,000 terms, and those terms are connected by more than 1 million links. That means that in medicine, there are roughly 310 concepts, and all those concepts are connected to each other by millions of different ways. This number of concepts is larger than the size of some complete languages. That means that in practical terms, that idea of building this megalithic system that can be used anywhere in any type of healthcare setting, that can be used in biomedical applications, that can be used for any type of information system in healthcare, would require building a system that would have this enormous amount of tables with 310 fields and millions of relationships between them. But this is the ideal situation. This is a situation in which all the experts about a given area of medicine or in healthcare would agree about what is the data model that define a specific concept. And let's call this data model that is agreed by everybody as the maximum data model. A data model for a given concept that includes everything that is related to a concept, and those variables that are related to this concept are included in a way that makes all experts satisfied with the way it was modeled. The problem is that healthcare is by far the most difficult area to reach consensus. Medical schools are very different from each other. Their points of view about a given concept can be completely different. Those different points of view about a certain concept might have something, might be related to the approach that is used in healthcare. The most obvious example is comparing allopathic and homeopathic medicine. You look at the same concept if you are an allopathic physician, and you look at the same concept in a completely different way if you are a homeopathic physician. So it is here I'm using an extreme case, but sometimes because of rivalries between two medical schools, the leaders of those two medical schools, they can have completely different points of view related to a certain concept. Because of that, we and Tim Cook came to this conjecture, the Cavallini-Cook conjecture, which states that the probability of consensus between two or more experts from the same field regarding which would be this maximum data model for any healthcare concept tends to zero. And in this situation, the possibility of building this megalithic system with 310 tables and millions of relationships between those tables is not feasible in practical terms, because for that you would have to achieve consensus to all those medical concepts, and the probability of reaching this consensus for all the concepts is zero. So why is this complexity one of the causes of the low implementation of information technology in the healthcare systems? What does this complexity cause? This complexity turns a computer science problem that we can say that doesn't exist, or at least is not critical in any other sector of human society, into a very severe issue in healthcare. And the name of this problem is, and I'm going to spell it very slowly because it's a complicated word, so to speak. The name of this problem is semantic interoperability. What is semantic interoperability? Because you will find a lot of academic papers discussing semantic interoperability and the ways to overcome it in healthcare. But usually, there's not a definition in those papers about what is semantic interoperability. And if you go to the textbooks in medical informatics, you will see there won't be a consensus about what is the definition of semantic interoperability, and some of the definitions are not clear. So I'll try to state it in simple terms. What is semantic interoperability? Semantic interoperability is the ability to send an extract of information from system A, which was developed independently. So system A will send a data extract to system B, and system A and system B were developed independently by two software companies. System A sends this data extract to system B, and system B and system A send data extracts to system C, and vice versa, in all the directions that you can imagine. This data interchange between those systems. And of course, here we can think about system D, system E. This is this ecosystem of healthcare applications. All of them sending data extracts from one to another. And all those information extracts will be semantically valid in all systems involved in this data interchange. What does semantically valid mean? Semantically valid means that all systems can read and understand all information extracts that are sent from other systems. So that means that system A sends a data extract to system B. System B receives the data extract from system A and understands it. System B is able to read, is able to save, to store, to persist this information with its context in its own persistent mechanism. And the other way around, system B does the same to system A, and both systems do the same to system C. System C can send data extracts that are semantically valid to system C. This is semantic interoperability. When I explain this way, usually software developers get very concerned, because they know that in traditional modeling this is not possible to be done. Just give an example of what I understand as semantic interoperability, and how would that happen in practical terms? You have here a primary care setting, and then a patient shows up with cough for 3 months and a low fever, and the physician, the GP, is not sure about the possible diagnosis and sends the patient to the radiology clinic. The system at the primary care setting sends that data extract to the radiology clinic system, and the radiology clinic system is able to receive and understand the semantics of the data extract that came from the primary care setting. And then the X-ray is done, and the diagnosis is a nodule in right apex. This information is included in the radiology system, of course, and this data extract from the radiology clinic is sent back to the primary care clinic system. And the primary care clinic system understands the data extract that came from the radiology clinic. The physician is still not satisfied, and so he wants to send the patient to the hospital to do a bronchoalveolar lavage. And then those two data extracts from the primary care setting and from the radiology clinic are sent to the hospital EMR, and both data extracts are understood by the hospital EMR. The information about the bronchoalveolar lavage, about the test, is included, and diagnosis is TBE, and this data extract is sent to the primary care setting system, and this data extract from the EMR is understood by the first system. So all data extracts were sent and semantically valid all across this history of this patient. And this is very common. This is what happens every day in all over the globe. This is what's happening to our patients. And at this point, they are just carrying pieces of paper, and that doesn't make any sense in the 21st century anymore. So that's the semantic interoperability issue that is so important in healthcare, and is not that important in other sectors of economy. And this is what we are going to address in the next sections.